This is our research group in Stockton, California. We're obliged whenever we give presentations to do a little travelogue for the university. So if you're ever in the Central Valley of California, we're about 90 minutes east of San Francisco, about 45 minutes south of Sacramento. Pretty campus, small university. My background in chronic fatigue syndrome, myalgic encephalitis, started about 15, 16 years ago. I originally came out of exercise and sports science. So to come upon a population where exercise did not seem to cure everything that was wrong with them was really antithetical to my beliefs at that time. I had a graduate student that came down with chronic fatigue syndrome, and she persuaded me to get involved in chronic fatigue syndrome research. More recently, I've also been the chair of the Chronic Fatigue Advisory Committee to the US Secretary for Health and Human Services. And originally I thought the science of chronic fatigue syndrome was difficult until I started to get involved in the politics of chronic fatigue syndrome, which is nearly impossible. One thing that we thought we did was beneficial in the States, that there's a stigma associated with the name chronic fatigue syndrome. It implies that people are just tired all the time. Of course, everybody says, oh, I have that. And so one thing we did, we actually persuaded the National Institutes of Health to attach myalgic encephalitis to the term chronic fatigue syndrome. And then what happened, we got a barrage of abusive emails from the people with ME who did not want to be associated with all those people that malingers with chronic fatigue syndrome. So we thought we were pleasing people, and we weren't. So I've never been to Sweden before, and I'm very happy to be here. And I must say I'm a big fan of the Millennium series by Stieg Larsson. And so it occurred to me that the stigma associated with chronic fatigue syndrome is a little like Stieg's heroine, Elizabeth Salander, where if we don't understand something, if something does not quite fit the normal mold, then we try to push it outside of society, we try to ignore it. So I came up with a new term for ME, chronic fatigue syndrome, and it's the disease with the dragon tattoo, the disease that people don't understand and people don't want to be associated with. And of course, Elizabeth had a pathological hatred for the medical profession, and who can blame her? And so she would not talk to physicians, and her reason was that they don't listen to what she has to say. And in part is that's because as physicians, as scientists, we don't always ask the right questions. And so the first step in understanding CFS, ME, CFS, is to ask the right questions. And so the illness has a wide range of symptoms, you know, from immune symptoms to pain to fatigue, to neuroimmune symptoms. And out of our research, one of the things that we do is that we do exercise testing. So I think I probably would meet the definition of a sadist. So we get people that are incredibly sick and we put them on a treadmill or an exercise bike, and we make them run or pedal until they're completely exhausted. And when we're not doing that, we make them sit in an audience and drone on for an hour for people that have struggle to stay awake and struggle to concentrate. So we inflict them doubly. So one of the things we do is we give out a little questionnaire and ask people to respond. How did you feel after the exercise test? And we asked the graduate students to collate these and do a little bit of pre-analysis for us. And one of our graduate students came running in the office one day. He says, I found the diagnosis for chronic fatigue syndrome. So you just give them a questionnaire, and if they fill it out and then ask for more paper, they must have chronic fatigue syndrome. Questionnaire on the right, on the left there, is the response of a normal sedentary control subject. The questionnaire on the right is from a chronic fatigue syndrome patient. A little graph. These are symptoms 3 days out following an exercise test. It's self-explanatory. The controls were pretty much over the test within 24 hours, as you would expect from a normal individual. We've got a whole range of symptoms with the chronic fatigue syndrome group going on for many days beyond the exercise test. Recovery controls, mostly, I think one subject, most of the subjects took 24 hours to recover. About 15% the remaining 15% were completely recovered in 48 hours. Only one subject with CFS recovered within 48 hours. The average recovery time was over 4 days. So clearly there's something called exercise intolerance. That doesn't mean that they just don't like exercise. There's a series of symptoms that follow physical exertion. And for many patients, these symptoms also follow medical exertion or social stress. So we see diminished functional capacity, a reduced working capacity, and then a whole range of exacerbation of symptoms. Interestingly, it's not a unique condition. And so with my background in exercise science, what we see in ME/CFS looks very similar to overtraining syndrome in athletes. So a sustained reduction in performance, often accompanied by other biochemical, physiological, and psychological changes. So what do we do when athletes are diagnosed with overtraining syndrome? Well, we tell them to rest. Well, you know, just take it easy. Get over it. We see a whole range of indicators. I could take overtraining indicators out there and just put ME/CFS up, and you'll see a whole range of symptoms that are very reminiscent of chronic fatigue syndrome. However, with chronic fatigue syndrome, we don't tell people to rest. What we do is we tell them to go out and exercise. So the very thing that made them sick in the first place, you have to go out and do more of it. And so there's a whole range of research out there suggesting that graded exercise is an effective treatment for people with CFS. Our experience has never been that that's true. So the people we see are clearly not the people that are appearing in these studies. So the studies report beneficial effect on physiological functioning and health perceptions. The reports on physical activity are mixed. What you see is a very low adherence rate to treatment, which often is not reported in the studies. And so you ask the question, do people with CFS really improve? The PACE study is probably a study that you're all familiar with. I constantly get emails complaining about the PACE study. In and of itself, it's not a particularly awful study. I think the problems with it is that the premise upon which it was based and what I would call a selective presentation and interpretation of results. So I'm going to focus primarily on I think it's their sole physiological, what I would call objective measure of function, which was a 6-minute walking test. 6-minute walking test was developed originally for people who couldn't do the 12-minute walking test. So these are people that have severe pathology, primarily heart and lung patients. So they started out with an N of 110, which is actually only 69% of the original study. Their original subject group were a selected high-functioning group of people diagnosed with chronic fatigue syndrome. They wouldn't accept low-functioning people into the study. Baseline distance was 312 meters. They had a 52-week program, and at the end of the 52-week program, they could walk 379 meters in 6 minutes. So I did a little bit of math on that, and that's an improvement from 3.12 kilometers per hour to 3.78 kilometers per hour. We work in miles per hour, which is a little lower, but it's still not very fast even in kilometers. I then converted that to metabolic equivalence. So that's something in exercise physiology that we do as a basic unit of function. And so that calculates at about 2 METs, or an oxygen consumption of 7 milliliters per kilogram per minute. That's not a very high oxygen consumption. In fact, that group with that oxygen consumption would meet Weber, New York Heart Association criteria for being severely disabled. If they had cardiovascular disease, they would not get a heart transplant because it would be deemed that they would not survive the surgery. So there's a degree of improvement there, but is it really meaningful? I could probably, most of our patients, severely disabled patients, can actually walk at that speed. It's a casual saunter up and down the office corridor. It's not as much energy as you expend having a shower. Could they do much else? I don't think so. Could I have gotten that improvement out of a group of people? Probably relatively easily. If they've never walked for 6 minutes before, the first time they do it, they're probably going to be a little nervous and hold back. The next time they do it, maybe they'll be a little more motivated to go up half a kilometer per hour. So for me, the study was not particularly meaningful in terms of, well, here we have a cure for chronic fatigue syndrome. Our own experience is that exercise done without careful thought can be counterproductive and actually make people worse. So this is an example of a patient of ours. Started out with an oxygen consumption of 21 milliliters per kilogram per minute, sort of what you'd expect for a normal sedentary individual. A couple of years later, that had dropped by 16%. And this person had been on a walking program. So they'd actually gone out. Every time they felt well, they would walk until they made themselves sick, and then they would rest, and they would walk again. Anybody here done that? That's the crash and burn approach. So one of the questions we need to ask is that let's get some objective measures of function. Let's find out how functional people really are. Let's not use things like the 6-minute walking test. Let's use tests that have scientific and medical reliability and validity. And so coming out of exercise science, we were familiar with exercise testing. We do it with athletes all the time. So we want to check on athlete performance. We put them through what we call a VO2 max test. And if ever you see any of the little news clips of a sports science laboratory, there's always somebody on a treadmill with a tube coming out their mouth. It's the stuff that we love to do. So it's a non-invasive procedure. It provides diagnostic and prognostic information and it evaluates an individual's capacity for dynamic exercise. That's not me, that's the American Heart Association. So the principle is that we have a built-in reserve capacity as human beings. Disease states reduce that capacity. This is not always apparent in the absence of stress. So when people are sitting around watching TV, you probably don't notice any difference. However, if you exercise them, then you induce stress, and you can start to see some of the effects of pathology there. So we stress the system. What you would expect to see is normal responses to stress, and then you can compare those normal responses with abnormal responses and come to some conclusions about how sick that person is, what effect has their illness had on their functional capacity. So we assess the function of the cardiorespiratory system, heart, lungs, and circulation. We determine functional capacity, focus on aerobic capacity. Main energy liberating systems, we have aerobic metabolism, simply with oxygen, very efficient. It's our long-term energy production system. And then we have the anaerobic energy system. No oxygen needed. It works best at higher workloads. It needs the aerobic system to charge it up. It's a little like a hybrid car. That the electric motor in a hybrid car will only work as long as the gas engine can charge that electric motor up. Byproduct of anaerobic production is lactic acid. So lactic acid is the enemy of performance. So as energy intensity increases, we rely more and more on anaerobic energy production. With lactic acid being produced, we see altered muscle chemistry, pain, reduced muscle function, altered enzyme activity, and a cessation or reduction in activity. Once the body can no longer metabolize lactic acid, you have to stop. It won't work anymore. So in exercise testing, we attempt to quantify aerobic capacity, i.e. VO2 max, and also assess anaerobic threshold, that point where energy starts to transition from aerobic to anaerobic, the point at which, beyond that, you're not going to be exercising for very much longer. A couple of ways of measuring this. You can measure it directly during a graded exercise test using gas exchange techniques. That's the tube coming out of the mouth. Or you can do it indirectly by recording heart rate response or onset of fatigue during a graded exercise test, and then apply regression equations developed from study populations. Many people adopt this second approach. Anybody guess why? What are the two reasons we do things for? It's easier and it's cheaper. And so it's easier and it's cheaper to do it indirectly. You don't need the tube. You don't need the expensive gas analyzer. You really don't even need a computer. So field tests, Cooper 12-minute test, 6-minute walk test. The 6-minute walk test I talked about earlier is an example of a field test. They're very easy to administer. You can have somebody walking up and down the corridor in the clinic or in the hospital. And then we have a variety of tests that tend to take place in a clinic or in a laboratory. Step tests, very often done with cardiac patients. Treadmill tests, running on a treadmill, and cycloergometer tests. So, as I said, advantage of field tests, they're easy to administer. ability to test many individuals at once, require minimal equipment. Disadvantages, generally they don't monitor blood pressure and heart rate, may result in aerobic capacity is estimated, may result in inadvertent max testing in some populations. That's quite interesting. There's been quite a lot of research done on the 6-minute walk test. And one of the most telling studies that I've read with cardiac patients is that they actually fitted the cardiac patients with portable cardiopulmonary testing equipment. So they could actually measure the oxygen consumption of those individuals while they were doing the 6-minute walk test. They found that over half those patients were maximally exerting themselves on the 6-minute walk test. The point of the 6-minute walk test is it's supposed to be a submaximal test. So if you assume somebody is doing a submaximal test and they're really doing a maximal test, then any interpretation of the results is going to be completely flawed. And so from our experience with chronic fatigue syndrome, ME, is that many of the patients in the PACE study, when they did the 6-minute walk test, it would not have been a submaximal test for those individuals. It would have been a maximal test of their performance. And, of course, the big problem, particularly for a disease that doesn't exist or is just in your head, and really it's just down to being motivated, motivation plays a huge problem, a huge factor in those tests. We get people in the lab, we can do the treadmill, we can do the cycle ergometer, we can do the step test. However, we're still not necessarily given to the idea of measuring gas exchange. So we can do indirect estimates of aerobic capacity. Again, we measure heart rate, we extrapolate from heart rate how hard somebody is working, and then determine how much effort they're exerting on the test. If we're using general population data for the regression equations, there's nothing to say that they're accurate for special populations. And in fact, there's a whole body of research, not ME CFS related, that suggests they're not. They don't apply to special populations. So the linear relationship between the measured variable, heart rate, and oxygen consumption may not exist, or the slope may be different. And this research has not been done with certainly to my knowledge, ME CFS. There's also a lot of other conditions that it's not been done with. Usually these norms are established in colleges and universities, or in broad spectrum studies where they get a control group for a cardiovascular group. It assumes that the response for a given age group is uniform. That's not true. It assumes that mechanical efficiency is the same for every individual. And the big thing, essentially, the American Heart Association has said you shouldn't use these tests at all, because nearly everybody with a heart condition is now on a calcium channel blocker. And so their heart rate is controlled by medication. So you put somebody on the test and you use heart rate, there's no way you can evaluate them. We get a number of chronic fatigue syndrome ME patients that are on beta blockers for a variety of reasons. They're sometimes used to treat migraines and various other, maybe orthostatic intolerance sometimes. And then you can find a whole range of studies where they work, but only for a specific population. Pathological populations show non-normal responses for heart rate. You see heart rate and blood pressure that doesn't respond in a variety of different conditions the same way that you would with normal individuals. And variables affecting heart rate, there's a whole range of them. It's not reliable. valid and reliable for healthy 18 to 40-year-old females. Can we then generalize to unhealthy 40 to 60-year-old females? Probably not. So the linear relationship will break down outside of specified ranges. I'm not a mathematician, but even I can understand that. So we advocate, this is not rocket science, this is not new, it's been around a long time. We advocate direct assessment of aerobic capacity. It keeps exercise physiologists in work so I can keep paying my bills. But having said that, we also think that it's the best, the most valid, and most reliable method for assessing physical function. We can get both maximal oxygen consumption, and something that you don't get with the estimates is anaerobic threshold. For any athletes in the audience, that they're probably well aware that their anaerobic threshold, or their capacity to exercise at higher levels, is probably more important for their performance than their absolute maximum. But because we don't work full out for hours and hours and hours, the limit to which we can work and recover reasonably is that anaerobic threshold. The US government has set various standards for 8-hour days, and they range around about 40% of maximal. And so for safe working conditions during a 40-hour week, 8-hour day for a normal healthy individual, they say they should be working at 40% or less of their maximal output. Interestingly, that corresponds to a little bit low where most people's anaerobic threshold is. Generally, it's going to be between 50 and 60% for most normal individuals of their maximum. So principles of gas exchange: aerobic metabolism burns oxygen and produces carbon dioxide. By measuring the difference between the two, it can be determined how much oxygen is consumed and how much CO2 is produced. So we all know that VO2 max corresponds with your capacity for endurance. It's dependent on cardiovascular limitations. Can the heart supply the blood to the muscles? Can the lungs supply the oxygen to the heart? And back to anaerobic threshold again. So through gas exchange, we can identify where anaerobic threshold occurs. So I'll revisit this a little bit later on because it has implications for a lot of things that we might do with ME/CFS. So it's going to be somewhere along that continuum of exercise intensity. You can't guess where it's going to be. You can't assume it's going to be 50%. You can't assume it's going to be 60%. Watching the Tour de France a few weeks ago, somebody mentioned that an athlete had been measured, and a cyclist, and his anaerobic threshold was actually 90% of his max, which is pretty amazing. We've never had a patient with an anaerobic threshold of 90% of their max. Generally, our patients have very low anaerobic thresholds. What amazes me is how long they will continue to exercise with us encouraging them above the anaerobic threshold when they know it's going to make them sick. But people often say to us, well, don't you have a problem getting these people to exercise to maximal? I say, well, actually, we don't. Surprisingly, people come in, they really want to know more about the illness. What more can we do to help your research? It's the controls that we have a problem with. You try recruiting a healthy sedentary control when you say, well, we're going to run you to exhaustion, or we're going to have you pedal to exhaustion. They go, yeah? And why would I do that? So with gas exchange, we get this rather nice little feature called respiratory exchange ratio, or RER. And it's really just a ratio between CO2 produced, so how much carbon dioxide are you breathing out, compared with how much oxygen are you consuming. So average R value with a modern diet, R is around about 8. With increasing exercise intensity, R value exceeds 1. Generally, anything, an RER above 1.2 is considered as an indicator of excellent effort. That person is at or as close to, as doesn't make much difference to their maximal capacity. So we have a direct measure of effort. We can say, no, that person didn't fake the test, they weren't malingering, which has important implications for disability assessment, which we also do. And we can guarantee that this is a true measure of their performance. We just look at a graph, and what we look for is when the carbon dioxide exhaled starts to exceed the oxygen inhaled, then we know that that person has reached the anaerobic threshold. Essentially, the line of the graph changes and we look for the break. And so we can come up with the anaerobic threshold. So indirect estimates of VO2 max can routinely vary by plus or minus 25%. So that's not very useful scientifically. It's not very useful in court when you're trying to argue that this person is disabled and the insurance company needs to pay them the insurance that they've been paying into for 25 years. The ventilatory threshold, that's that transition between aerobic, anaerobic, the point at which the CO2 overtakes the oxygen, correlates highly with blood lactate levels. The nice thing is we don't have to stick a needle in anybody to measure blood lactate levels. We can just do it with gas exchange, breathing, and correlates strongly with aerobic performance. And measuring gas exchange allows you to accurately and reliably determine effort. Useful for scientific purposes, useful for medical purposes, useful for litigation and legal purposes. So another statement, the American Heart Association strongly endorse RER as a measure of effort. And routinely, the American Heart Association publish on cardiorespiratory endurance testing. So the latest paper, they've had about 3 major papers come out that every time some new information is brought up that they will add to these papers. So we determine aerobic capacity, relates to level of function, useful for constructing exercise protocols. Disclaimer here, I'm not against exercise for people with CFS ME. I do not believe it is a cure. However, anybody that is sedentary is going to suffer the effects of that. And so just because you're ill from something else doesn't make you immune from secondary effects of inactivity. And so if activity can be incorporated into a person's life in a safe and reliable way, then we still think that that's beneficial. It's not going to cure you. But will it help? Yes, it may. So oxygen uptake and anaerobic threshold strongly correlated to aerobic performance. And direct measures of aerobic capacity are much more accurate, especially in special populations and disease states. So that's my advert for cardiopulmonary exercise testing. And we need to push this because a lot of scientists are starting to develop their own protocols, and that they have no reliability and they have no validity studies done, and therefore potentially they make any other results that you get meaningless. That there's a whole body of research on cardiopulmonary exercise testing. There are population norms. There is a variety of comparative data available from different pathological populations that usefully we can compare ME/CFS with. So we don't think that people need to reinvent the wheel. There's a test out there that's worked for a long time. There's no reason to suppose that it won't work with chronic fatigue, ME. And so one of our early studies, we persuaded a drug company to incorporate this protocol into their drug trial. They just wanted to do it for duration because it was cheap and easy. Fortunately, I work at a university, so they pay me for doing this stuff. And so we said to them, look, we will do it, but we want the cardiopulmonary data. Will you let us do that if we don't build that into the estimate that we're going to put together for the testing? So they let us do cardiopulmonary exercise testing on the patients, but they only paid us for doing a time test on a treadmill for duration. And so we got a lot of data. And so the patients, most of the patients fell into the mild to moderate or moderate to severe category. Quite a large number were non to mild, and then a smaller number was severely disabled using American Medical Association criteria for disability based upon oxygen consumption. So it's not necessarily surprising data with a large number of people. But remember that questionnaire that we had at the beginning with all the writing on it from the ME/CFS patients, and the time to recovery, and all that range of symptoms. Well, when we gave these patients those questionnaires again, and what we found was that even the patients that appeared less sick on the exercise test still exhibited all of the same symptoms and delayed recovery that the people that were at the other end of the spectrum. So we started then to understand this concept of post-exertional malaise. The idea that I can be feeling perfectly good one day, as the patients say, I was having a good day. Took advantage of the good day, cleaned the house, played with the grandkids, went skydiving, bull riding. And boy, I was sick the next day, went to bed, didn't get up for 2 weeks. And so when we looked at those questionnaires, we started to wonder what was happening here. It was not showing up necessarily in the exercise test, but it was showing up later in the patient response and the patient's reaction to the exercise test. Also, with a single exercise test, it's quite difficult to separate the effects of the test from something called detraining. So if I give evidence in court on behalf of a patient, so we've done a disability evaluation for a patient, the insurance company doesn't want to pay, and so that it goes to court, and I get called up. My least favorite thing to do is go to court and testify. And so the attorney for the insurance company will invariably ask me, could these effects be due to detraining? Is all we need to do is put these people on an exercise program and get them fit again? Well, with a single test, sometimes it would be hard for me to say, well, I don't think so, but it doesn't work in court. They don't take maybes. You have to say yes or no. And so we developed the exercise test retest protocol. So I said at the beginning of the seminar that I'm a sadist. Well, what we've done now is we've added a second test in. So we'll give you a test on Monday to exhaustion. We ask you to come back 24 hours later and do the same thing again. What we're actually looking for here is we're looking for some objective indicators, some metabolic indicators that would correspond to this nebulous symptom post-exertional malaise. So we sit people on the bike and we exercise them to exhaustion. Not quite that far, I might add. And so we're looking for induced post-exertional effect. We use the bike now. We don't use a treadmill anymore. If anybody's thinking of doing this, I advocate the bicycle. It's harder to fall off a bike than it is a treadmill. Believe me, sometimes the patients need to be held on the bicycle. It gives them a little bit of time to recover while we take some post-exercise measures. So if we want to do heart rate and blood pressure, anybody that wants to stick a needle in somebody immediately post-exercise, it's not a good idea that they're standing up at the time. The other thing that it does for us, it gives us another very useful measure that I'll talk about in a little while. With a cyclergometer, we can also get a measure of workload. So we do it in watts, Newton meters. So how much work are they generating for that particular oxygen consumption? This was some early research. So what we see here is peak VO2 for CFS and controls. CFS is the red group. Initially, their performance was not too dissimilar from the control group. In fact, those measures were not statistically significantly different, the initial measure. Second test, typically what you see with a normal healthy control group, in fact, you see the same thing with heart disease as well, they do a little better on the second test. There's a learning effect. So people know how to do it, they're a little more efficient, they get a little better. Our CFS group didn't. As you can see, a dramatic drop on test 2. So our conclusion was that the repeated exercise test demonstrates the effect of post-exertional malaise. It quantifies the magnitude of the post-exertional effect. It helps to inform the mechanisms of the response. We've got a whole range of metabolic data that we can look at, and we're still looking at data from years ago till we get round to it. And it's reproducible. The test protocol can be reproduced, the measures of effort are reproducible, all the techniques are reproducible. So we see an atypical recovery response. So essentially it's an abnormal stress test. An abnormal stress test meets disability criteria, certainly for the US Department of Social Security for cardiovascular disease. The nice thing is if you have a test that meets criteria for one disease, they can also apply it to another disease. So we have less trouble with Social Security. I don't know what the equivalent would be, but that would be the state paying for your disability as opposed to an independent insurance company. So that early study, we saw a 24.5% decrease with our chronic fatigue syndrome patients. Other illnesses, it's well documented that 78% is the normal variability for this test. However, this is data from a much larger second study. Interestingly, our results have been replicated by other people. So we have a colleague over on the East Coast that's replicated those results. A gentleman, Ruud Vermeulen, in the Netherlands has also replicated our results. This is a second group. This group of individuals, there's about, I think this is an N of 60 plus ME-CFS patients. Interestingly, this group were a lot lower functioning than the first group. And we find that the drop in peak oxygen consumption is not quite as robust for this group. You see it, but it's not as much. And so that caused us to start to think, well, why might that happen? And one of the hypotheses that we have is that there's actually a floor effect. That there's a minimum amount of oxygen that you need to function, and once you get below that, you'll see less of a drop. What we do see is we see a decrease in that anaerobic threshold, so that kicks in a lot earlier. But the biggest finding out of this set of results was a reduced work efficiency, where we see a huge drop in work output measured in watts on the bike or Newton meters on the bike. And you can see by the greenish graph there that CFS and controls start out pretty much similar on test 1 for workload. Test 2, that workload has dropped exponentially. It's gone up with the control subjects. So I'm now a much less efficient processor of oxygen to produce energy. Other people have come up with a variety of theories and hypotheses for this effect. I'm not going to favor one or the other at this point, but certainly that research is ongoing, and everybody has their own favorite little theory. But clearly, ME/CFS are exercise intolerant. They have a reduced physical working capacity overall. That is exacerbated by physical activity. It appears that the aerobic energy system is compromised, and activity invariably exacerbates symptoms. We never get anybody that doesn't come down with a whole range of symptoms following the exercise test that sometimes make you feel terribly guilty. We've had people admitted to hospital following the test. So cardiopulmonary exercise testing can provide objective measures of fatigue in CFS-ME, functional endpoint for clinical trials, disability assessment are 2 primary uses. Single exercise test may be insufficient to distinguish between CFS-ME and sedentary controls, particularly if you get somebody that's rested, somebody that's having a good day, that they may appear completely functional. It's one of the problems that patients tell me they have, is that people only see me when I'm well, and so they ask, well, what's wrong with you? You seem perfectly fine. Well, I only go out when I'm well. You don't see me when I'm in bed and I have to crawl to the bathroom on my hands and knees if I can even make it. It's a quantifiable stressor. So I have a measure of how much stress I put this person under. It's a standardized test. It can reveal abnormalities across multiple systems. Availability of the respiratory exchange ratio, exclusive to expired gases. It's not available from any other measure. It's the most accurate and reliable gauge of effort. So if I'm doing a clinical trial, I want to be sure that my control group, my placebo group, and my treatment group are both giving the same amount of effort. I don't want somebody saying, well, this group just tried harder. And that's the reason for the difference between the 2 groups. In the same way that I don't want to be in court and saying, well, could you explain that with motivation? Was the person just not motivated to try on the test? I say it doesn't matter, I can tell. We always tell people at the beginning of the test is this is going to be absolutely no use to you if you don't give 100% effort. And everybody does. So I've got a little bit of time left. I wasn't sure how much time I had today, so I've got 3 endings to the presentation. And we may actually get to the 3rd ending if I go through this quickly. So we use some of these principles for patient counseling. So this is my graded exercise, not really, and the other word that we can't mention, cognitive behavioral therapy. Cognitive behavioral therapy is not a cure for chronic fatigue syndrome. I've said that. Does that mean that it's not useful? If it can be used to help somebody deal with their illness, if it can be used to help somebody have a better life, then it is useful. One thing we have to do with a lot of patients, particularly those that are coming from a background of being an avid exerciser, so they define themselves as an exerciser, so when they can't do that, then their self-esteem goes through the floor. So we say, you have to redefine exercise. Exercise now doesn't look like exercise did before you were sick. If you still want to exercise, you have to come up with a new concept of exercise. So that's one of the first things that we have to do. And so our principle of exercise therapy is based upon training short-term energy systems. In fact, we see with CFS-ME that very often short-term energy systems of patients, long-term patients, seem to have adapted. This idea that they can go quite a long way into their anaerobic threshold. You know, and that will be the day that you give everything. It's a birthday party. And you know you're going to do it. So I don't like to share stories without permission, but one of your colleagues brought us here in a taxi and was talking about walking up the Great Wall of China. When she knew it was going to make her sick, but hey, you're in China, you're next to the Great Wall, you have to walk up it. And you deal with it afterwards. So short-term energy systems work, long-term energy systems don't. We want to avoid oxygen debt. That's when you see athletes bent over at the end of the 100 meters, sucking in air. They can't hold a conversation because they're trying to repay that oxygen that they've borrowed against. They're trying to metabolize the lactic acid. They're trying to get that lactic acid out of the system. What we see for ME/CFS is that activities of daily living will create oxygen debt. So I have people sat in our office at the end of an exercise test. We do a little bit of a debrief, and we'll tell them, well, this is where your anaerobic threshold is. What this means is that doing the dishes, going upstairs and having a shower are all activities above your anaerobic threshold. So this is why you're exhausted 10 minutes after you get up in the morning, because you've probably bounced off your anaerobic threshold 3 or 4 times. So you've done the equivalent of 3, 4 100-meter sprints just getting up in the morning. And you have to pay back that debt with rest. So, and as we know, the better able you are to repay, the lower interest rate you get. Go figure. I've about got science worked out. Finance I'm still struggling with. Normal individual, 10% interest, CFS 50% and above. So expect that if you incur an overdraft, if you go over your limit, you've got some paying back to do. Plus that you won't let you use your card anymore. In fact, what they do in restaurants in the States, they may take it off you and cut it up. So we ask patients to use activity biofeedback, maintain heart rate below anaerobic threshold. If we can measure your anaerobic threshold, we can tell you the corresponding heart rate, we can give you a heart rate monitor, we set the alarm, beep, stop, sit down, take a rest. If you won't do it, your caregiver, significant other has also been clued in. I just heard your alarm go off, you better sit down. I'll finish doing the dishes. I'll take the trash out. Now, don't use this for ill, so you only have to use this for good. Don't use it to get out of doing things that you don't want to do. Use a perceived exertion scale. Maintain a log. So, rating of perceived exertion. If it feels above anything that's not fairly light, it's probably going to make you sick. And here's a typical activity log. So activity, meal, heart rate 90, RPE 10, body position sit, that's under your AT, that's probably okay. Dishes, heart rate 120, RPE 15, that's standing, that would be above that person's AT, that's going to cause them a problem down the line. You get the idea. You start to get in tune with the activities that are going to make you sick. So ask the right questions. What activities make you feel ill? How do you feel the next day? Do you experience post-activity, post-exercise relapse? Is physical activity, so if you're exercising, is that changing your ADLs? Say, well, I can exercise every day, but I can't do anything else. That's not a particularly useful way to live your life. That's not going to help your relationships. But I don't have time to talk about those things. Types of energy stressors: physical, cognitive, mental, social, emotional, spiritual. Not only does the patient have to adapt, the therapist has to adapt. We do quite a lot of presentations for physical therapists, sometimes called physiotherapists. Interestingly, they may be the people that see chronic fatigue syndrome the most often. Very often the physician will refer somebody with ME/CFS to a physical therapist to retrain them, to condition them. So they need to be on the lookout for CFS ME symptomology, because reconditioning will not work with those individuals. Pacing, body composition, joint protection, assistive activity planning. Sten was going to make this presentation available to everybody, so he does have a copy. I don't mind how many copies he prints off. I've added a few extra things, but it's mostly only the comedy, so you can do without that. Use all advantages that you can, that they're available to you, use them. You know, if you need a scooter to get about, use a scooter. Use the answering machine. Don't stand up on the phone, sit down, put a stool in the shower. Have a chair halfway up the stairs, rest. We call it analeptic exercise, exercise that is refreshing. You have to recover from it. If you've not recovered within 24 hours, then it's not useful to you, it's not helpful. Remember to breathe. We find patients get a lot of benefit from breathing. Dose-controlled interval training is important. Do a little bit. Rest at least as long as you exercise, probably twice as long initially. If you feel okay the next day, maybe up it a little bit. It's trial and error. If you feel bad one day, say, I'm not going to push myself, I'm going to take it easy today. Identify your coping style, stay out of debt. It's a good maxim. Use the anaerobic system, train the anaerobic system, not the aerobic system. We find that it's empowering. People tell us, I feel in control of my illness again. I can do stuff. It's not dictating my life to me. I get an improved quality of life, sense of control, off the roller coaster, off the couch. Are you going to be running a marathon soon? Probably not. But if you can avoid symptoms coming back, then you're going to feel better. If you can avoid that crash, that's the key. The fewer number of times that you crash, the better you're going to feel. I'm 5 minutes over. Do you want me to just finish up quickly, or shall I get off the stage now? Case study, so 17-year-old female, it's not just an older person's disease. We increasingly see younger people with chronic fatigue syndrome. It just so happens that they don't very often get diagnosed. Very low functioning, very tired after the activity, recovery time, whole week unable to participate in any activity. This is a 17-year-old. We gave them a 2-day exercise test. They last 8 to 12 minutes. So that's a total of 24 minutes of exercise max. The person's incapacitated for a week, a 17-year-old. So we asked her to stop a walking regimen, use a heart monitor to monitor activities of daily living, breathing for recovery and relaxation, play enjoyable activity, mini golf. She wanted to go to a concert. So she adapted, made a number of modifications to her life to help. She started to see some benefits. She could go and play miniature golf. She was tired the next day, but was able to do it. So she was tired, but not wiped out for a week. Some resistance exercises, gentle, easy resistance exercises. Physical therapists are well able to prescribe and monitor this sort of activity. It's the sort of thing that they'll do with aged populations. A couple of things: body position, recline and rest while driving. She wanted to go to a concert, so we said, well, yeah, somebody can drive you, but put the seat back, lay down, rest while you're being driven to the concert. Wear support hose, so you see all athletes are starting to wear these strange stockings now that look awful, that support the legs. People wear them on aeroplanes. Stay well hydrated, don't forget to drink fluids, use the disabled parking sticker, spray bottle, healthy snacks, plan to rest after the concert. Concert was great, followed the suggestions, and they really helped me. The day after the concert I was tired, but on Monday I only felt achy. By Monday night I was back to my pre-concert energy level, thank you. So that was a plus in that person's life, just by adapting, no wonder drug, no bolt from above, it was just sensible precautions. I'm just going to finish very quickly by revisiting my original statement about some of the stigma associated with this condition, and that's been around for a long time. I've really enjoyed Stockholm, and one of the reasons that I've enjoyed Stockholm, my first time here, is that I love history, and there's so much history here. And one of the benefits of history is that it's supposed to stop us making the same mistake again. It's one of the lessons we learn from history. And you may or may not have heard of Florence Nightingale. So National CFS Day is Florence Nightingale's birthday. So I call this the Florence Nightingale effect. Florence actually, after the Crimea War, came down with an illness that today looks very similar to chronic fatigue syndrome. She spent a lot of time in her bedroom. She was not well liked for it. People didn't understand what was wrong with her. They couldn't diagnose her. So you see quite a lot of reference to her being a malingerer, to being a manipulator. I think she's the founder of modern medicine rather than just modern nursing, actually, because everybody knows nurses do all the work. And this was a statement that she made, which I think is very appropriate today. There are no such thing as specific diseases. It's pretty stupid to think that there are. There are only specific disease conditions. It doesn't really matter what you call it, ME, CFS, fibromyalgia. There are hundreds of thousands of people who are really, really sick. The medical profession is not helping them. Their government representatives are not helping them. And they need help urgently. Thank you.